Now I would like to present our speaker for this evening's presentation, Dr. John Millard. John Millard is a board certified by both the American Board of Plastic Surgery and the American Board of Surgery. He received his Doctor of Medicine degree from Georgetown University School of Medicine and completed both a surgery and plastic surgery residency at Duke University. Dr. Millard is the founder and chairman of the Advanced Body Sculpting Institute in Denver, Colorado, and is nationally and internationally renowned for his expertise in breast and liposuction procedures. He was a pioneer of the Vaser high-def procedure in the United States and teaches courses on this technique with his partner, Dr. David Broadway. Dr. Millard has been named one of the world's top cosmetic surgeons by Tadler's 2008 Beauty and Cosmetic Surgery Guide. Please welcome Dr. John Millard.
Thank you. Are you there, Christy?
I am. I'm switching you over to presenter Dr. Millard, so you can go ahead and share your presentation.
Right. I'm waiting for it to come on. Good. Application. Keynote. Share. And give me a chance to get the presentation up full. That's showing up for everybody?
Looks good, Dr. Millard.
Okay. Well, tonight we're going to talk about human fat transfer and liposculpture. And what I'd like to introduce is a concept both from a business standpoint and from a pure practical practice standpoint. What I've learned that, and first and foremost, is adding human fat transfer to your liposuction or liposculpture has really increased the satisfaction both for myself and practicing as a liposculpture physician, has also increased my patient satisfaction. It's been a huge adjunct economically to our practice. And with the introduction of 3D and high-def techniques, we're seeing increasingly requirements for both fat removal and fat placement. So fat grafts can also be used as in your iatrogenic liposuction deformities as well. What we're going to talk about tonight, let's talk a little bit about history. You have to know where you're going, and you can only understand that by understanding where we've come from. And we'll talk about that just a little bit. And then we're going to move on to the vaser fat and human fat transfer. We'll discuss a little bit about viability issues, and then through the remainder of the presentation, we're going to be sharing our clinical experience, which with the vaser fat is approaching 4 years now. We'll touch a little bit on skin retraction theory, harvesting techniques, and then specifically discuss body areas to include the female breast and the breast augmentation, and a technique that we've actually pioneered through the Advanced Body Sculpting Institute, the male chest augmentation, another procedure that was introduced and advanced through the Advanced Body Sculpting Institute. We'll talk a little bit about gluteal augmentation and hand rejuvenation as well as face rejuvenation using autologous human fat. You know, the concept of injectables really isn't new. It was introduced in the late 1800s. Paraffin was attempted with not much success. We were injecting silicone early in the century, causing all sorts of problems. And Miller first introduced the concept in 1926 with injectable fat, having sort of followed up with Niebuhr's work in 1893. They essentially took clumps of fat, usually they were large, and tried to introduce them into defects and or scars, etc. It wasn't until the early 80s with the advent of modern liposuction that fat injection really took off. So most notably, initially we were just essentially taking fat out of our canisters in as sterile technique as possible and introducing macroglobules. I think that everybody's familiar with Sidney Coleman's introduction of his technique, which essentially progressed us from the macroglobule technique to more of a microglobule technique, and I'm going to talk a little bit about this. This is Sidney Coleman's book. Earlier techniques relied on large clumps of fat, and fat being a fairly delicate structure, very poor in blood supply, even in the human body as it sits right now, was not a very good substance in large clumps to be taken in by the human body. A lot of it sort of dissipated, didn't really get infiltrated with capillaries. As we all remember through our training, the first 2 to 3, 4 days of fat transfer really is more along the lines of the same nutrients that a skin graft gets, and that would be through imbibation, which is essentially the serum, et cetera, that comes through the tissues before there's some starts of capillary ingrowth. And then with capillary ingrowth, Sidney Coleman's technique really borrowed on increased surface area, where you use microglobules instead of macroglobules. I like to really compare it to, taking your garden. And if you compare the macroglobule technique of fat transfer to just taking your garden, digging it all up and throwing it in the other side of your yard, maybe a plant or two will take. But if you individually plant each small plant and carefully transport it over to the other side of the yard and transplant it, you're going to get a much higher yield. And that's the metaphor that most, easily explains this concept. And essentially, eventually these fatty tissues anchor to the host, and we apply these fat droplets or miscules via blunt cannula technique, and eventually via a volume effect. As you'll see on this next slide, we're able to place large amounts of fat and create a volume change in whatever structure we're trying to contour. This takes us eventually to vaser and autologous fat transfer, which initially was thought to be sort of counterintuitive, i.e., the earlier concepts of fat emulsification with ultrasound were that of cavitation of the fat globules. And it became, at least clinically apparent to several of us about 4 years ago, that this fat was actually viable. We started using it in small amounts in certain areas just to see if it takes. And with a tremendous volume over the last 4 years, we've proven essentially that the fat takes every bit as well as using Sidney Coleman's technique just through our clinical experience. I'm going to now introduce several slides that sort of talk about the theory of cavitation and sort of evolve it from that of cavitation of the fat globules themselves to really cavitation or creation of gas bubbles through the liquid which displace fat. And that's shown in this first slide, essentially introduction of tumescent fluid into the patient. There's bubbles that occur as this fluid is equilibrating with the air outside the IV bag. And then under the cyclic compression and, rarefication yielded by the ultrasound, these bubbles grow. Eventually, then getting adjacent to mature adipocytes, the adipocytes are essentially clumped in fat lobules. And adipocytes, which can range from 30 to over 100 microns in diameter, they're relatively loosely bound as they compared to the endothelial cells of a blood vessel. And as such, they're more prone to separation or displacement. You can see here, again, fat cells on the order of 75 to 100 microns in diameter, arranged in clusters, fat cells around blood vessels, connective tissue, etc. And these are areas that are easily infiltrated by tumescent solution. So, if you take this cavitation phenomena that we talked about and sort of apply it to the fluid or gas bubbles that are created through tumescence, we eventually are able to affect the bonds between these individual fat cells or small fat globules, and over time able to separate the fat cells or fat globules from one another using the ultrasound. So we're really using cavitation of the fluid around the fat cells to cause displacement. Ultimately, with the idea that we, using these microbubbles, cavitating the tissues between the fat cells, we end up with sort of free-floating fat cells or fat cells that are easily removed intact using the vaser system. And again, you can see here the emulsified fat, where eventually we're able to get these small clusters of fat globules or cells, which are actually much more easily used in the process of autologous fat transfer, sort of borrowing on Coleman's, phenomena or theories of using a microglobule technique. I like to really call this myself more of an ultra microglobule technique. If anybody on the panel here who's used Coleman's technique has ever had a chance to use vaser aspirated fat. The Coleman technique, while much better than the traditional large globule placement technique, still gets clumped and kind of sort of clots up the cannulas on a fairly regular basis, and we see much less of that with the vaser fat. The vaser fat tends to almost go in more like Juvederm in my book, and so it just tends to go in much smoother. So again, with all of this, and with the 3D techniques, as you can see with these techniques, especially the high def up on the right on the slide, the 3D techniques are dictating much more of a need for fat transfer, as we're essentially able to perfect our results. We're able to get a higher standard of result. We're able to affect change to a much greater degree. Considering traditional liposuction was really a debulging procedure, we are now creating shape and form like we were never able to create before. Such was his dream by Gasparati some 25 years ago. And with that, you're not just going to be able to accomplish your goals with fat removal alone. It's going to require placement of fat as well to achieve your final goals. This is a paper that was just recently released, a study that was put together most notably out of Longacre's group in Stanford. And ultimately, what they were able to show is through the number of to the several people they accomplished lipoplasty on using the third generation ultrasound or the vaser in many body areas, the researchers showed no difference at the cell level between treatments from traditional lipo versus vaser lipo, and they were essentially, to quote the article, they suggested, and I'll read right from the article, the conclusion suggests that exposure of the adipose-derived stromal cells to ultrasound energy during tissue harvest by means of third-generation ultrasound-assisted lipoaspiration does not impart a negative consequence towards their proliferative capacity or osteogenic potential. And so, essentially, they're saying they're viable. It's a great article. To understand a little bit about what we're doing, I'm just going to touch a little bit on skin remodeling as well. There's essentially an inherent property built into the skin where it is able to contract if forces are released, or the isoelastic forces are released underneath it. Removing a volume of fat in the subdermal layer allows this to happen, and we're able to do that pretty effectively with ultrasonic energy. As you can see here in this slide, demonstrating pre-treatment, and then after traditional deep and intermediate fat removal, we've really, on that second slice, left the skin untouched. It's the removal of the superficial, the subdermal fat that allows the maximal tissue remodeling. It's shown in this slide, and even more so in this slide right here. As you can see, removing that subdermal layer of fat allows the skin to essentially shrink wrap around its smaller volume or 3D contour, whichever you create. And this shrink wrapping obviously is affected by both patient age, sun damage, etc. But depending on those variables, you can get a significant amount of skin contraction and shrinking around your new volume. With that said, let's talk a little bit about instrumentation for harvesting and trauma to the adipocyte. There's many things that can actually affect these, what we've described as poorly vascularized or fairly delicate cells. The small aspirating cannula that we use, centrifugal forces, multiple transfers, too strong a power vacuum, exposing the fat to air and ultraviolet rays, stirring and scraping the fat as we do with some of the older techniques, and even the possibility of sepsis with our harvesting technique. And as such, as you can see here, this technique of using a jar system was essentially banned in the United States, at least by the FDA, because for several reasons. Sterility, and this particular jar at above 30 inches of mercury was prone to implosion as well. So with that, a system was created called the Tissue Trans Mega 1500 cc large volume fat transfer system, which we use here at our center. What we've noticed is a significant improvement in efficiency of time in fat harvesting. I like this system because it really sort of mitigates many of those negative variables, keeping a closed system essentially, minimal transfers, mitigating the trauma with multiple transfers. And ultimately, one of its really positive effects is on those thinner patients who every bit of fat counts. Every bit of fat that comes out of your lipoaspirate can be trapped or contained within the system. And we've seen cases where we've put every bit of fat back in one area that we've sucked out of an adjacent area. So it's a great system, and it's a system that's actually produced by another company that's partnered up with Sound Surgical, and it integrates right into your Vaser system pretty seamlessly. It was even designed to work best with a venting mechanism, which is already in place with your Ventex cannulas. So we use this pretty much exclusively now at our center, and it's changed the way we think about fat harvesting as well as fat transfer. All of a sudden, when it becomes very easy to store or at least obtain fat cells for further placement when there isn't the brain damage of squirting fat across the room onto the ceiling, trying to get as much, trying to get fat out using the older techniques, there's less resistance on the surgeon's part to put fat back in as well. So that's more of a convenience thing. So with that said, I'm going to move on to the female breast augmentation, which we here at the Advanced Body Sculpting Institute introduced in the United States here in May-June time period after the American Society of Plastic Surgery sort of finally gave its blessing. Though we had been doing it internationally for a couple of years and sort of, again, through the ABS Institute, pioneered our own technique, which I think is actually as effective, if not superior, to the techniques that have been advocated thus far. With that, let's talk about how traditional technique has evolved. Essentially, the traditional technique of fat transfer was one of placing fat into the fatty tissues of the breast only, and it did not include liposuction as part of the procedure. The high-def fat transfer technique that we use includes fat transfer both under and into the pectoralis muscle, as well as fat transfer into the fatty tissues in the breast. It also includes high-def liposculpture methods and such. We think this is an advantageous technique. As you can see here in the illustration, up in the top cutout right, we're not only placing fat above and below the breast tissue, but we're placing fat into the pectoralis muscle, which is rich in vascular structures, and below the muscle as well. And I like, it's funny, the most successful ideas are sometimes the simplest ideas. And those of us who had a history of doing muscle transfers and muscle transplantation work in our reconstructive days would have been well to think and remember that the pectoralis muscle is a very similar muscle to that of the gluteus maximus. They're fairly similar in shape, blood supply, and type. And once we introduced this technique in the United States, it was almost obvious that this should have been probably done some time ago, and it works quite well. And here at the Advanced Body Sculpting Institute, we've performed over 100 procedures now with significant success, and I'll share some of those results with you. Within the male, and as you can see in the female as well, we're using some of the same techniques that we've been doing for several years in the male pectoralis augmentation. I'm going to show you a little bit. There's the 3 slides here just showing the power of using high-def sculpting technique around the breast. This is a female who did not have any fat placed into her breast, under her breast, nor did she have implants placed. This is just the technique of using high-def liposculpture alone, and what sort of what it can do. As everybody will see here, the nipple to inframemory fold distance from left to right increased about a centimeter, and the size perception is much larger than that on the right than the left. And this is using high-def sculpting techniques only. That's the first step in what we do with our essentially our high-def breast augmentation using autologous fat transfer. Take advantage of the fat that's around the breast to give a relatively large appearing breast even before we place fat. As you can see here again, and in the lateral view as well. So we then place fat both in a similar manner as we do in the male into under and above the pectoralis muscle, with giving results like this. And so it's actually a very nice technique for those women who, for whatever reason, desire no implants or desire not to place foreign substances or bodies into their body or devices into their body. We can get one size increase predictably, usually, sometimes two, in our patients, and it's a nice technique that borrows from the autologous fat transfer to the male pec. With that said, I'm going to move on to the male chest augmentation. This is actually a technique we've been using going on 4 years now, and essentially was the technique with which we developed the female counterpart. And essentially, the male aesthetic standard really hasn't changed since the time of Michelangelo's David. A well-defined both inferior and lateral pectoralis major border defines the male chest, as you can see here in these two slides. How do we achieve that? Again, through a combination of lipo selection using a high-def technique, and then autologous fat transfer into the subcutaneous tissues of the male chest, both above the muscle, into the pectoralis muscle itself, and underneath the pectoralis muscle to get a maximal result. Again, it's a technique that we've had between myself, Drs. Broadway, and Dr. Hoyos. I believe now we're probably approaching, if not over 100 cases. So, and then we'll share some of our before and afters with you. One of the big advantages to this technique is its natural appearance. For those of you out there who've used the male pec implant technique, it's probably most dissatisfying in that in a lot of men it gives them more of a female shape. It looks, they almost look like they have gynecomastia. You have much more control with this technique about where you place the fat. You can really, as you introduce this technique to your practice, will notice male pecs come in many shapes, sizes, and in many deficits, and you can really tailor the technique to the patient, meaning some patients require more medial fullness, some lack more superior fullness. In some cases, we're combining it even with gynecomastia cases where we're actually taking down the fat in the inferior aspect of the subcutaneous tissue and placing fat in the same area underneath the muscle, but it creates more of an athletic shape. I like to describe this technique as sort of kind of turning, if you think of the male pec as a piece of filet mignon, we're sort of turning it into Kobe beef. So, but it works well. We have a high satisfaction rate amongst our patients, especially the older ones. The older males tend to have a tougher time getting that upper pull fullness in their chest, and you can see it really shapes it out, gives it a really nice athletic appearance. So, got a couple more slides here that sort of really make this pretty obvious. This is one of the Canadian patients that came down here for us. Guess they like the strong appearing muscles up there in Canada as well. And in our practice, we do this very commonly with the high-def techniques on the abdomen and torso as well. It's a really wonderful procedure. It adds about 15 to 20 minutes of time to the end of the procedure and adds about another $3,000 to $4,000 in physician fees. So it's not only a wonderful adjunct to the male chest, but it's a wonderful adjunct to your bottom line. So. And again, you can see the natural appearance you get with this versus using pec implants. So, with that, I want to go on to the more traditional uses for fat transfer. We're all familiar with that. Includes both the fat in the gluteal area and the face. Again, we here at the Abs Institute use a combination in every one of our procedures of both liposculpture and fat transfer. Let's talk a little bit about, it's nothing new. I think the modern technique of autologous fat transfer to the gluteal area goes back to the late, part of the last century. The Cardenas Camarina article is probably the best, and it really espouses the power of both liposuction above the gluteus in the flank area, as well as the fat being injected into the muscle itself. So it's a great technique. It's been around for a while. It's time proven by the works of Mendieta down in Florida and Roberts as well. So, and again, it espouses the power of both liposuction above and below the gluteal area. I would say perigluteal liposculpture, liposuction gives you the best results in addition to autologous fat transfer to the gluteal area. Again, reminding ourselves of the gluteal anatomy and where it sits in relationship, specifically to musculature, to the overall gluteal aesthetic. Let's also remind ourselves the differences in what's being striven for in both the male and female augmentation. And here at the Abs Institute, we're not only doing a lot of female gluteal augmentation, but we've now introduced the concept of male gluteal augmentation as well, and I believe that's going to explode in the next several years. It's something that men don't talk about, but themselves, even exposed to the concept, I think it's one of those sort of silent things that bothers men, especially as they get older and they lose volume in their breasts, in their gluteal area, and they lose that athletic appearance of their bottom. So that's something we'll be talking about a little bit. Again, recognizing and understanding what affects and makes a female male gluteal aesthetic somewhat different. The spread look on the male buttock versus the pear shape on the female, with the more distinct gluteal fold on the male, but shorter and then longer on the female. Again, I think we all know what we're looking for, though. So is it about the gluteus maximus alone? Not really. Like we talked about earlier, every one of these procedures benefits from adjunctive liposculpture as well. We take advantage of this with aggressive vaserlipo selection of the sacral triangle. Try to pull out the sacral dimples or sacral holes, which are aesthetically pleasing. And then the perigluteal lipo, which includes both typically lateral thigh and banana fold and medial thigh, as well as sometimes even movement of the gluteal fold itself, as well as flank and hip lipo as well. And so the best procedure is going to be a combination of both lipo and fat transfer. So, again, this just sort of shows and kind of brings out the importance of relevance of using a lipo sculpting procedure along with the fat transfer to the gluteal area. And then we're very strategic with regard to where we do place our fat. Only some of it goes into the muscle. Both the inferior and lateral aspects of the gluteal anatomy are devoid of any muscle, and replacing it more in the subcutaneous tissues in these areas as well. So you really need to define the relevant anatomy you're trying to improve. Sometimes that even includes placing fat up in the upper medial pillar, trying to increase the length of the essentially the gluteal cleavage to make it more aesthetically pleasing as well. And so that's again depicted here with this little illustration that we've created. Again, this is a slide that shows the patient prior to the lipo with the vaser and aspiration. This shows just the power of enhancing the gluteal area by removing the fat aggressively in the hip and flank area, and then with placement of fat, you see a significant improvement in the augmentation as well. These slides depict fat placed within the muscle by MRI at 48 hours and at 2 months. Again, you can see a pretty decent amount of fat that's been sort of that Kobe beef appearance to the gluteus muscle there as well. So this is a wonderful way of showing how fat takes in the gluteal area. Again, pre-op 48 hours and at 2 months. There is some dissipation of some of the fat, though. So what do we do with the vaser? We use the pulse mode. We keep the power less than or equal to 60%, and essentially just allowing enough energy to facilitate extraction of the fat, but not emulsification of the cells themselves, just emulsification, or I should say cavitation of the tumescent fluid in a way that disrupts the bonds between fat cells and fat globules. This just shows the power of lipo, and then lipo with the gluteal augmentation again. And then we'll go through a bunch of results here. And again, your aesthetic goals can be variable depending on what part of the country you're in. I think as you move south towards Miami and LA, you tend to be doing a little bit more of this. Up here in Colorado, I don't see as much of this. I do see some of it with my Hispanic population, but I am seeing a large, significant growth in my male patient population for this procedure as well. So, again, we'll be coming out with a at least a white paper soon on the techniques that we use and the aesthetic goals. You can actually see here, this is a great slide to show the power of placing not only fat both in the gluteal muscle itself, but you can see that lateral trochanteric depression, which has been improved upon with fat placed there, and you can see the relatively, how would I describe it, unappealing gluteal cleavage on the left and significant improvement of it on the right, and that's been accomplished by subcutaneous fat placement in the medial upper pillar. So our aesthetic goals are not always just about volume. They can be about shape and even reshaping the gluteal cleavage if properly applied. Turns out the shorter your buttock cleavage, the more male you appear as well. You can see the same thing here. It's not just about volume again. And the results are very reproducible. Again, very aggressive lipo contouring up in the waist area and enhancement both of the volume and especially in that medial upper pillar to increase the cleavage distance. So, in summary, gluteal enhancement with vaser fat is very successful. You lose about 20 to 40% of what you initially place, so we tend to overtreat the patients initially somewhat. It does improve contour. Sometimes less is more. And it's a perfect match with your liposculpture, placing the fat using autologous fat transfer techniques. Let's talk a little bit briefly about hand rejuvenation. It's a great technique, actually, to introduce yourself to the application of fat to the human body. Essentially, this is a patient of mine. She's about 3 months out in these pictures. And as your hands age, they're the telltale sign. If you've done everything else, you've had your facelift, you've had your face, laser resurfacing and everything else, and you look young, the hands are going to give it away. As the hands age, they lose volume, the tendons become more prominent, the veins and blood vessels and the knuckles all become more prominent. And a very simple technique of, in this particular patient, 33 cc's of vaser-derived fat was placed in her hands, and her hands appear much longer younger just because of that alone. So this is a great technique to add to your practice. It's a fairly simple technique. It's probably one of the simplest techniques that we do for fat transfer. In fact, Sidney Coleman, in his teachings, recommends this as one of your first introductions to fat transfer. It's probably one of the simpler techniques you'll do as far as placing the fat. So, and then face rejuvenation, that's been around for quite some time, and we all know why. There's both skin aging and volumetric aging. Skin ages with time, and there's loss of elasticity, wrinkling, and as you can see here, this isn't just skin alone. The whole concept of facial aging is about loss of fat and fat volume. Becomes really apparent in these several slides coming up here. It's not just the skin. There's obviously volume issues between this young 20, 30-year-old and this 70 or 80-year-old. So is the skin the only difference? Well, no. We wouldn't be here if it was today or tonight. As you can see here, these slides sometimes don't go as fast as I want them to. But, so we're in the face, we're starting to think about volume as well. And as you can see, the difference between this 40-some-odd-year-old female and her counterpart on the right at 20. Again, you can see it here. And here. So, and in this lady in her early 20s and the same lady at 45, you can see the volume loss is especially notable periorbitally and up in her cheek area, but also notably along her jawline, chin. Really, there's not a part of the face that really is free of volume loss as we get older. So So that brings us to what Sidney Coleman's been working on forever. That's the concept of autologous fat transfer to the face. This is where we first started introducing vaser fat in our practice, was to the face, and with some tremendous success. Borrowing from Sidney Coleman's recommendation and techniques, we can do an entire face fat transfer in about an hour to an hour and a half. Shown by Coleman's markings here. And I use it as part of every one of my facelifts to sort of prevent that really deflated look. This is a lady that's a year out, and I would argue this is a post-weight loss patient. She would not have done as well with just a rhinopectomy alone. Another young lady we worked on noticed her cheeks most notably, and this was with a fairly this was not an aggressive smash technique either. A lot of this is the fat. So, and then face fat alone, as you can see in this lady, who I tried to talk in a neck lipo at the time, but she wasn't interested. And then again, you can see it in that previous patient, the power of fat. And this is probably one of the most dramatic results I can show you. She had a facelift out of Beverly Hills and came to me, and I got to do the really make her, I think, what was the simpler of the two techniques, put the fat in her face, and really take what was a relatively well done facelift, and it just needed some fat to round it out. And you can see how much difference the fat improves her look over just the facelift alone. So that's it. I'd like to thank everybody for at least participating in this part of it. Now we're ready for questions.
Great, wonderful. I'm going to go ahead and take the reins back here, and what we will be doing for the attendees is I'm going to be sharing some web content for a video that we are going to be reviewing later on, but as that's loading for everyone, we will be taking some initial questions. So hold on just a second. I'm going to transfer back here, and we'll go ahead and start with the web share here on this end. And what you all see on your individual computers, you'll see a video starting to play, and each of you should have your own control of the video. So if you went ahead and hit the pause button, that'll allow this video to load so that we don't have any of the buffering interruptions when we actually decide to review it as a group. So we'll go ahead and start off. And Dr. Millard, the first question we have here is concerning the viability of fat cells. There was a lot of initial, it seemed, data out there that ultrasound imploded the fat cells, and why is it that you think vaser is different from some of that original data that was put forth?
Well, I think a lot of the original data that was put forth was actually unstudied. It was hypothetical. I mean, if you read the book, especially I like Kekel's and Rorick's book, it was all theory. I don't think anybody knew what was happening. And the ultrasound lipo book most recently published was in the mid to late 90s. And it wasn't until people started, I know there was a couple surgeons down in South America that we actually met 5 or 6 years ago, just about the time of the introduction of the vaser, that were sharing some of their MRI work with other ultrasound. They were using, if memory serves me, either Mentor or Lysonic, and they were actually seeing the same thing we're seeing here is intact fat cells. So I don't know that, I think the cavitation was a theory for fat cells, and I think we've sort of disproven it. There was never really any good data to show initially, at least scientifically, that we were actually destroying fat cells with ultrasound. It was all really theory, and I think we're finally getting good studies. We're getting this most recent study at Long Acres, and I know there's been some work done with electron microscopy, and and fat that's been prepared by ultrasound, both vaser and non-vaser ultrasound prepared fat, both showing intact fat cells. So I think it was a matter of finally having some good scientific method.
Great. Next question is, what do you feel is the minimum harvest amount needed to have a good result in gluteal augmentation?
Harvest amount?
Correct.
Really depends. We just did a male recently who only really needed enhancement of his trochanteric depression, and we use a technique of lateral fat placement only in the male, and I needed on the order of like 200 to 300 cc's per side. It could be as little as 90 cc's a side if you're trying to fill in a trochanteric defect on a female. That same trochanteric depression on a male, which makes him appear athletic, makes a female buttock appear masculine. And so it depends on your aesthetic goals. It could be as little as 90 to 100 cc's per side, and as much as 750 cc's a side. It just depends what the patient's starting with, what their goal is for ending up with. And again, also, I mean, if you're looking at a 4'9" female versus a 6'2" female, it's all about surface area there as well too. So I think the real question is, what do you think the patient's going to need, and can you get that amount of fat? That's the questions we ask clinically in our practice. What do I think I need? Do I need 500 cc's per side? Then I look at my harvesting areas. Do I have 500 cc's per side on this patient to get the fat I need to augment her gluteal area? That would be the real question. And it's unfortunate. Sometimes the patients that need the gluteal augmentation the most are your thinnest patients, and they don't necessarily have the proper amount of fat that you need to obtain your results. So that's the question. Is the fat there that you desire, volume-wise?
Do you spin harvested fat after collection with the Shippert system? And do you ever freeze fat for a secondary augmentation?
The answer to the first question, what was the first question again?
Oh, I'm sorry. Do you spin harvested fat after collection?
No, only on the face. I only spin it with the face because I'm a little more specific about my amounts. I will tell you, with Shippert harvested fat, you can have some minor variability in the concentration of fat to say fluid in the syringes that you're using versus and on the face that can be a major difference. And so for the face, I will spin the fat just to be more precise and get kind of a higher percentage of fat in that syringe. A fair amount of the serum that you would normally pour off or wick off comes out in the infernate in the bag that he has prepared. Though I haven't completely ruled out or entertained, I'd like to see a large, like a 30 cc syringe spinning system. I think that might be something that would be potentially helpful in the future, but we don't on our large volume stuff. It doesn't, I don't think the centrifuge has been proven to actually enhance the fat take as much as it's a little bit better for giving you a more precise amount of fat per syringe.
So the second part of that question, Dr. Millard, was do you ever freeze fat for secondary?
No. We don't freeze fat for secondary use, in part because there's a proper way to do it, and the proper way to do it is cost prohibitive. You really have to, if you're going to place fat back in the human body, you need an alarm. You need an alarm system. You need a state-of-the-art system to store the fat. There's only at the end of the day, I think you're talking about cryopreservation of the fat, and unless you've got that system set up and all the back checks, you really shouldn't be freezing fat and storing it in your refrigerator. I think that's a recipe for disaster.
Next question is, what is your experience with adipose-derived stem cells with fat transplant?
Very little at this point. The only experience has been through kind of listening to the rumor mill. A lot of it's going on overseas. I know in Japan, when we were over there teaching recently, they were doing a bunch of it. I think it has huge potential. I know there's 3 or 4 systems out there right now that help you harvest this stuff and process it. We have not done much with it in the United States yet. So.
How do you prepare the fat before transfer? Do you add any protein-rich plasma or other additives or fat stem cells to help enhance viability?
Not at this point.
Do you use the FAMI technique or do you get results with subcutaneous injection?
It's funny. The FAMI technique, I think that's essentially what we're doing with the pecs and the glutes. I mean, the FAMI technique is essentially placing fat in the face, if memory serves me, in both the muscle and the subcutaneous tissues. And I do believe in that technique. My colleague that I worked with quite a bit in placing fat into the face actually studied with this gentleman overseas, and I think there is some real power to trying to get some of this fat into the muscle. I don't know how effective we are getting into the muscle of the face. I mean, those are fairly thin muscles for anybody that's done a facelift or a dissected cadaver head. But I think as much of it, I believe you get a higher yield or a higher take of fat that's put into the muscle than you do in the subcutaneous tissues.
Great. At this point, let's go ahead and show part of the video, and then we will have some additional Q&A time after the video has been shown. So if I could ask...
My video will be up there, Christine?
Right now it's showing my video on my screen, so I think everybody should be there. If all attendees could move basically the scroll bar back to the beginning of the video presentation, it should be fully loaded now on most of your systems.
I don't have it on my system.
You're not seeing it on the screen?
Nope.
All right. Well,
content media objects will be displayed. Let's see. It should be on the WW YouTube, right?
Correct. It should be on the main WebEx screen, Dr. Miller, too. If you go back to that master screen, it should be in the content panel there for you.
It's not.
All right. Well, then we can certainly, I can shoot you off the link quickly so you can be following along with everyone else. Looks like some are seeing it and some aren't here. So it looks like the web content is sharing for some and not necessarily for others. I'm going to send out a chat that has the address for the website. So if for any reason you're not seeing it live on your WebEx screen, you can look on a separate browser as we're going through this.
Could you go ahead and I'm going to give you you need to send it for me to John M, John, at Bodyvolve, BODEVOLVE.com.
Great. For attendees, you should now see the address in your chat panel. You can go ahead and click on that link to be able to see what we are talking about. Dr. Willard, let me know as soon as you receive that link, and we'll go ahead and move forward.
My virtual machine showing up on yours? Let's see if I have it here.
As we're waiting on this, attendees too, please do continue to put questions in that Q&A panel on the right-hand side of your screen, and like I said, we will continue that after the video. Dr. Millard, are you ready?
I am ready to start the video. It's on 1 second. I'll take it to 0. Okay. Let me know when to start.
Great. Those of you who are sharing on the web content, go ahead and hit play on your screen, and likewise for those of you looking on your own separate web browser, and we'll go ahead and get started.
So right now what we're seeing here is we're essentially pulling the mega tissue 1500 cc system. This is a second generation system that Shipper's designed, pulling out of its sterilely prepared package. That with Dr. Schwartz, who's in this video, is holding in his hand, is the device that he'll attach at the end of the harvesting procedure to harvest the fat placement with a no-touch technique sterilely into the 30 or 60 cc syringes. What he's showing here is a hose that connects directly to your vaser system. Your vaser system can be turned down as well as far as its pressure, and we'll show that. But this essentially what would traditionally be connecting your Ventex hose to your aspiration port, you'll connect this short hose to the aspiration port. And then the other hose goes to your cannula. And it's a vented system again. The venting allows the fat to get into this container relatively easily without clogging or collapse. And as you can see, Dr. Schwartz here is actually harvesting fat through those ports there. And even as we speak, the fat is getting separated out, and essentially what will happen, the fat will go into the sterile bag. It's very similar to what I would describe as you would see with a bag that would be used for donated blood. And so you've got a sterile bag within this sterile container, the fat, and its surrounding content, the infernate, which is typically serum and lidocaine and saline, etc., will start to separate out even as we're aspirating. So this container can hold up to 1,500 cc's of lipoaspirate, which is a combination of infernate and supernate. You can see the fat going in through the tube. You can actually see fat starting to separate out in this supernate in this bag, the infernate being the fat insoluble contents, water-soluble contents. And you can see here what's wonderful about the Ventex system is you can adjust your aspiration pressure down to 15 or below inches of mercury. We recommend 12 typically in our center here. This minimizes the pneumatic damage to the fat cells. And it's a nice system. Sound Surgical integrated a device onto the machine that allows you to micromanage that aspiration pressure as well. So really converting this Ventex aspiration system into not just an aspiration system, but a wonderful harvesting system as well. So there's nothing else out there as far as aspiration goes like it, in my opinion. Now he's completed his collection process. What he'll then do is take the same canister. And oh, by the way, in most centers, we don't torture this surgical assistant having him hold it. We actually, it does come with a 3-foot stand that this very easily and sterilely can stand on. You take a Mayo stand cover and throw it over the stand, and then slide the canister on that Mayo on the essentially the pole, and then we turn it upside down and re-slide it back onto the 3-foot stand to let the fat and its infernate separate out. But here he's going to force his surgical assistant to do some isometric exercises here to accomplish the same thing. At any rate, I guess the point is you don't need to have the bucket and the towels there. You can, it comes with a nice stand. Spend about 15 minutes letting the fat separate out from the fat insoluble products, and then you're ready to dump the infernate off, and you're left with essentially a high concentration of viable fat cells, which are easily aspirated from this system that Dr. Schubert has designed. Well, we've noted in our center, we've switched over to using 30 cc syringes. They're a little easier to work with. As you can see, Dr. Schwartz here is placing the harvesting transfer system onto the device, having completed the aspiration process. All of these rely on minimal lengths of hosing. We're trying to minimize trauma to the fat tissues, and as such, don't use long lengths of hose. Here he's releasing the infernate before he starts to harvest the fat cells, and what he'll be left with on top is the viable fat cells. And then from that point forward, you can harvest those with the his syringe technique. As you're going to see here, you'll apply a syringe, whether you want to use a 10 cc syringe, a 20 cc, a 30 cc, or 60 cc syringe. It's really your choice. You can use whatever you'd like. Harvesting your fat, and it's ready to go. You've minimized the amount of transfers. You've minimized the touch, and as you can see here, you've never exposed the fat to air or any significant ultraviolet radiation, and you're ready to place the fat using a no-touch technique back into the patient. The other things I can tell you about this, in our practice, the harvesting technique here sped us up by almost 75%. What used to take us a couple hours essentially takes us no time at all. It adds a little bit of time on your aspiration time. What would normally take 20 minutes may take 30 minutes to aspirate because you're using lower aspiration pressures versus the typical, as we would use here, Endeavor 22 inches of mercury of aspiration pressure. We're using 12 inches of aspiration pressure, so it does take a little bit longer to harvest the fat versus traditional aspiration technique where you just put the fat into the canister alone. Again, asepsis and minimal chance for fat contaminating the fat with bacteria, etc. The other thing we've noted is the ideal cannula is the 3.0 millimeter cannula that comes with your Ventec system. It tends to get the smallest, really globules and minimizes clogging when you're trying to place the fat back into the patient. So, especially when you're using the Lorlock systems. There are specific syringes you can buy out there that are fairly expensive that have a slightly larger diameter, but at the end of the day, it's not really cost effective, and we use basically the cheap, inexpensive Lorlock 20 or 30 cc syringes, and you can see here he's ready to augment whatever he's going to augment, whether it's the glutes. The pecs looks like he's augmenting this young lady's glutes here. So, and as you can also see, there's no fat on the ceiling or the walls as there would typically be when harvesting using other methods out there, at least in our facility. We had a problem with the old techniques of clogging and everything else, which just made it very painful to harvest fat. So, and we pass the cost of the device directly onto the patient. It's on the order of between $300 and $400 per canister, and we just charge a one-time fee to the patient for that. The other thing is that 1,500 cc canister is reusable should you need to harvest more than 1,500 cc's of aspirate. A 1,500 cc aspirate is typically going to give you anywhere between, at a low 500 cc's upwards of, to 1,000 cc's of fat. So, I think that's it.
Great. I am. Terrific. Thank you very much, Dr. Millard. We'll go ahead and continue on with the Q&A at this point. The next question we have for you, Dr. Millard, is what is the average amount of fat transferred to the breast to increase one size?
Usually, again, depending on base width of the patient, a small base width female is going to require less versus a larger diameter more. Just like a narrow implant on a small girl can increase 3 sizes, where a larger volume implant on a wide-chested woman can get you up 1 size. But I would suggest to you that on average we're putting upwards of 300 cc's or more fat into most patients. So.
Great. This is a question from a Vaser user. Does it matter which probe you use prior to the aspiration phase for the harvest? Do you have a preference for 1, 2, or 3 rings or a certain diameter?
3-ring. First of all, the 2.9, if you can get away with the smaller cannula, it's kind of nice. I think it's a little less total energy going into it. We've used that with tremendous success, but haven't seen much. We've seen just as high a take of fat using the 3.7 cannulas, and I'm typically using a 3-ring.
After fat transfer to the gluteal area, when can a patient start sitting on the buttock again?
It's funny. That was a point of discussion here recently, and my partner and I do things a little differently. But at the end of the day, if you understand how sitting works, they should be able to sit right afterwards. You're not sitting on your buttock when you're sitting on your ischial tuberosities. The bigger question is, should they be laying on it? We try to encourage them the first couple of weeks not to, up to 3 weeks, not to really spend a lot of time laying on their on their butt, on their fat. But when you're sitting, I think it's less of an issue. You're really kind of sitting on your ischial tuberosities.
Certainly. Do you use different cannulas for injection depending on the site, so the buttock versus the face?
Yes, I use the Coleman face system. I think it's a brilliant system. It comes in 3 different types and 2 different lengths, including a very small diameter cannula that's used up around the eyes. The cannulas we use for the body are larger, on the order of 2 millimeters to 3 millimeters, and in diameter, and we use those. We order those through shippers. They're essentially the same Coleman design, essentially a non-sharp cannula, blunt tipped with the hole sort of placed back a few millimeters. The whole concept of the Coleman system is for the more fibrous areas, you have kind of a slight cutting to your cannula as you're injecting, but I sort of prefer the approximately placed hole with the atraumatic cannula, and you can get those. You can order those through Shipford as well. He's got a nice cannula system.
What are your average vaser times per 100 cc's infiltrate with fat transfer?
Anywhere from 1 minute to 2 minutes per 100 cc's.
Right.
It goes up a little bit. If I spend 20 minutes on using, I'm doing almost everything at 60% vaser mode now. So, when I was at 80%, I think my times were a little shorter, but you don't go up that much more. I get a pretty efficient emulsification at 60%. If it took me 5 minutes to do it at 80%, probably takes me 6 minutes at 60%.
Do you do superficial liposuction first and then deep harvesting, or the other way around?
Yeah, let me introduce the concept here. I like the concept of subdermal lipo, superficial lipo, and deep lipo. I think the lexicon or the terminology we need to use needs to be subdermal, meaning lipo right underneath the dermis, on the topmost layer of the superficial fat. That's subdermal lipo. That's the lipo you accomplish to release the skin from the fat to accomplish skin tightening. Then anything between scarpus fascia and that layer is superficial lipo. Anything between scarpus fascia and the muscle is deep lipo. So I like to speak in terms of 3 different types of lipo: deep lipo, superficial lipo, and subdermal lipo. And the funny part is the superficial lipo in a thinner patient may be the only fat you have. When you get down to a 10 or 11% body fat patient, you're harvesting from the superficial layer, essentially, because most of these patients don't have much deep fat. So it becomes even more important to have an efficient system that allows you to work well within the superficial fatty layer, such as the vaser system.
Have you noticed any higher incidence of calcification doing fat transfer to the breast that would interfere in any way with detection of breast cancer?
Don't have enough experience with it to answer that question, but no. I mean, we followed the literature very closely. The numbers that we have are fairly low still with the women, but we've had no significant problems with calcification whatsoever. The literature sort of, the real issues were whether you could identify the calcification of fat necrosis versus calcification of breast cancer. I think it's really been finally sorted out. I mean, the radiologists really don't have much of a difficulty to detect between the two, to be quite honest. At least in reviewing the literature, I think that's one of the reasons that the American Society of Plastic Surgery finally went ahead and let this kind of go forward and let the doctors start doing it.
Do you change your probe and cannula usage depending on the different levels of fat that you're treating?
Yes. On the thinner skinned areas in the body and on females, I tend to go down on the subdermal part to a 2.9 cannula versus the 3.7 cannula. I do that just because of the risks of cutis mamarata, vascular changes in the subdermal plexus that you see sometimes on women and in thinner skinned areas such as the medial thighs. So yeah, I do.
What is the longevity of results in the breast or kind of the absorption rate of fat that you've witnessed in the cases you've performed?
Upwards of 50% absorption, and we've got longevity going out right now at about a year, at least where I was able to see my post-ops. Again, we've been doing this overseas, which is not as easy to follow up on your patients to get before and afters, but I was able to get afters on one of my patients after doing this last September. We're about a year out.
Do you do the chest augmentation after high def of the male chest, or you do it first?
Yeah. I do all the lipo first to the male chest, then I finish it up with fat transfer. And we have 4 years of results on that, so we have longevity on that going. Also was one of the reasons I felt very comfortable proceeding with the female technique.
What is the key advantage of using a lower vaser energy? Do you use the lower energy only when harvesting, or do you really do it for all of your fat removal?
I do it for everything now. Mostly, I'll be quite honest. When I started, I had the advantage of early on in my career being able to learn superficial and subdermal technique within about a year after the vaser was introduced in the United States. I got time spent with D'Souza Pinto and Di Giuseppe. Came back to the United States where I was doing deep-only ultrasound with the vaser, and I started doing superficial work. And one of my first patients was my wife, and the amount of pain she experienced using continuous mode at high energy versus just deep-only was enough for me to start asking questions about total energy delivery. So I've spent the better part of the last 5 years doing everything I can to decrease the amount of energy being delivered, the first of which was switching to vaser mode, which significantly dropped the amount of pain patients had post-operatively, especially when you're working the subdermal and superficial layers, and then tweaking it down from 80% to 60% reduced it much further. So, again, I think energy over time, hurts more.
How long do you think you can safely vaser per 100 cc's of infiltrate?
I'm going to qualify that. The FDA says 1 minute per 100 cc's. I think if you are aspirating, if you've infiltrated your deep and superficial layers, and you're realizing some of that infiltrate from the superficial layer is going to migrate to its deep layer, I can spend a minute in the deep and a minute in the superficial. So kind of gets almost a 2-to-1 ratio for my, I'll almost do 2 minutes per 100 cc's when I do that. Again, I qualify that I'm doing it at 60%. I'm doing it in vaser mode. Let's remind ourselves that the 1-to-1 ratio was for the 3.7 cannula. When you're using the 2.9 cannula, I think you're getting much less energy delivered. So there's a whole bunch of variables that go into that. And, again, monitor. There's devices out there to monitor skin temperature and everything else. And I think you need to, if you're going to be pushing those higher times, and especially if you're one of those people that doesn't use a lot of tumescence, you're putting yourself at risk. So it's a loaded question, only in that if you review the literature, which I've had to for a couple legal cases, the reason the 1-to-1, the 100 cc's to 1 minute sort of came out of Tebbett's work in the turn of the century when they were seeing a lot of problems with burns and seromas with the previous first and second generation devices. So, a significant amount of tumescent, that really very wet technique sort of mitigates against most of that or all of that.
How much touch-up do you need to do to achieve a satisfactory breast augmentation with purely fat transfer?
I tell all my patients that they probably want at least a minimum of 1 fat transfer touch-up after the first procedure. Do they all require it? No, I'd say maybe on the order of 25 to 30%. We tell them that because of the unpredictability of the fat take, and we also tell them they're going to pay for that second, third round of fat transfer. Typically, you can do it in the tumescent setting by that point, and we're putting it more in subcutaneous tissues, which is easy to do in a tumescent technique in your procedure room. But it doesn't matter whether you're doing fat augmentation of the breast, the chest, fixing a contour irregularity. I think a safe bet is to tell them, you may need upwards of 3 touch-ups at least. Under promise and over deliver is what we try to do, and make sure they understand out of the gate that there's going to be a cost associated with each touch-up.
What tricks do you have to control where the fat goes for male chest and female breast augmentation in order to give a smooth breast contour?
Incision placement, which we teach at our courses, helps you get under and into the pec muscle, and observation of fasciculations of the muscle when you're placing the fat. You'll know you're in there when the pec or the glute fasciculates.
Have you had any luck with fat transfer using laser lipolysis, or what is the viability of fat after use with the laser?
That's a big question mark at this point, but I think it deserves study. I think as the lasers progress and some of their mechanism that's used to it gets away from the selective photothermolysis, using other things such as photomechanical effects can actually, I think there's probably some merit for at least at this point, there's merit for study.
Are you performing a fat transfer and the Vaser high def technique under local anesthesia, or is it purely under general?
In my practice, I'm doing the Vaser technique purely under general. We've got several students out there that are doing successfully under tumescent technique.
Great. Does the cannula size number and the number of rings affect, do you feel, the upper safe limit of the Vaser time in a typical Vaser case?
I don't think so. I think it's all total energy. I really don't.
Great. And the final question here, Dr. Moore, we've had a few questions come in concerning the Vaser high-tech technique. Would you mind just giving us a brief summary of what that is? And attendees, just so you know, there will be a webinar specifically on the Vaser high-def liposculpture technique actually next Tuesday. But Dr. Moore, if you would just give a brief summary of that would be wonderful.
Vaser high-def, essentially, at the end of the day, I like to say that up until this was introduced, the world was flat. Now the world is round. And Dr. Broadway is going to tell the whole story in a week, but going on 5 years ago, I made a trip to Colombia and discovered Alfredo down there, who had really revolutionized the 3D technique. And what Vaser high-def is recognizing that the limitations of traditional deep-only lipo, with its inherent inability to really get significant skin retraction nor affect 3D shape, an enabling technology came along at the time, namely Vaser, that allowed us to work in the subdermal and superficial layer. And Gasparati, 25, 30 years ago, in his book on subdermal superficial lipo, knew that once we were able to do this, we were able to really significantly affect skin tightening and, most importantly, shape. He took the technique from a debulging technique, or just basically debulking technique, to that of being able to go into any body part. Now the arms, we do it on the legs. We take the patient's own musculature as a template, not just the six-pack, but the space between the muscle groups. And then with that template, we enhance the definition that most of them have worked to some degree to achieve in the gym. I mean, I like to say most of us have muscle definition. Most of us are just hiding it. And what this does is selectively removes and leaves fat in a way to enhance the muscular contour and shape between muscles throughout the human body. Is that a good description?
I think that is terrific. Thank you, everyone. That is going to conclude the webinar for this evening. On behalf of Sound Physical Technologies, I'd like to thank you all for attending. And for more information on fat transfer courses and Vaser high-def courses, please visit the Advanced Body Sculpting Institute, which is simply advancedbodysculptinginstitute.com. Please note there is a fat transfer and superficial sculpting course coming up November 20th through 22nd, and also a Vaser high-def liposculpture course coming up December 4th through 6th. For those of you new to Vaser lipo, if you have any additional questions, please don't hesitate to contact us either via our website at vaser.com or call toll-free 1-888-471-4777. Again, thank you for attending and have a wonderful evening.
Thanks, Christy.